Looks like Melissa started it. So I have just started the recording of this open meeting in compliance with CMS. For the record, prior to doing so, I announced that Palmetto GBA would make an audio recording of the open meeting and consented on behalf of Palmetto GBA. I would like to just make a few comments at the beginning. The objective of the open meeting is to provide an open venue for stakeholders and interested parties to comments on a proposed LCD. The presentations are summaries of the comments and due to time constraints may not be comprehensive of all concerns. Presenters are asked to submit written comments and any supporting published peer-reviewed literature by June 8th, 2024 to a.policy@palmettogba.com, which will be addressed in detail in the response to comment article. Presenters have 15 minutes and at the conclusion of the time will be muted and the next presenter promoted. Please be mindful of your allotted time frame to ensure you can share your closing remarks before your time concludes. I would like to mention some key points to consider. The FDA classification or granting of a code is not sufficient to meet the criteria for reasonable and necessary. The proposed policy is based on evidence and does not utilize FDA regulatory pathways for coverage determinations. While the policy does limit frequency to 4 applications and 12 weeks duration per episode of care, there is a clear pathway for use of additional applications or time when medical necessity to ensure beneficiaries have access to care for complex and difficult wounds as communicated by stakeholders in the prior listening sessions. The policy is limited to diabetic foot ulcers and venous leg ulcers, and any outside and use outside of these indications is at an individual MAC discretion. The policy intentionally does not limit consideration for coverage to specific study designs, but focuses on sound methodology, which allows investigators multiple options for future investigations while ensuring quality evidence is considered. With that being said, let's go ahead and begin with our first presenter.
Morning, this is Jenny Feit. I'm the first presenter. MiMedx thanks Palmetto and all the MACs for having these meetings. And we recognize that in addition to just the setup of the meeting, there is also a lot of background work, and we appreciate all the representatives at the MACs that have assisted us through the last few weeks. I am speaking today not as a clinician, but in my background as a certified coder, auditor, coding instructor, and I have been in wound care revenue cycle for the last 20 years in the health policy and reimbursement side. MiMedx really thanks the MACs for examining all products consistently and addressing many of the stakeholder concerns from last year. We are really pleased to see that those 2 key items were addressed. We do have some concerns that I'll walk through in this presentation that we believe addressing can lead to a stronger document. Specifically, how to add products, the 4 application as the benchmark for exceptional cases, the KX modifier, some issues with the ICD-10 diagnosis list, and then some ambiguity remains for DFUs versus VOUs and LCD versus the article. The proposed LCDs largely address product evidence requirements. We believe in going through it, we see that the MACs addressed all products consistently regardless of path through the FDA, which we believe is fair and aligns with the AHRQ. Due to processing variations, the AHRQ 2020 technology assessment stated that each of these products must be studied in a properly conducted clinical trial, and we believe this aligns with that. Our concerns are more around the pathway in the process for getting products onto the covered list for future. At the moment, I know other stakeholders will comment that right now there is no explicit RCT requirement, which we now recognize is specific to the MAC's design, to allow open doors for other types of evidence. However, we did notice that the risk of bias uses a different tool than the AHRQ. We do have some concerns that this could set a precedent that the MACs will cover studies with high risk of bias. But our primary concern is how the MACs will address future products and studies. Right now, there's no described process other than perhaps the reconsideration process. We believe this would really be time and resource prohibitive. Going by the MAC level, if you look at the sheer volume of skin substitutes and the reconsideration process, there are a lot of steps and a lot of meetings. And even though this is rolled out as local coverage determinations on a multi-jurisdictional, it really is in essence a national coverage policy, and having to go MAC by MAC could yield unequal coverage. So we would ask that the MACs provide a clear process for adding future products to the covered list, and that those decisions could be made jointly across all MACs. The big data study, we do have concerns. We are really pleased that the LCDs allow a path forward for patients who are responding well to skin substitute treatment, and we acknowledge that the pathway is there for greater than 4 applications and greater than 12 weeks of treatment. So we applaud that as progress from the last drafts that were withdrawn last year. We also believe the LCD and article provide clear thresholds and documentation requirements. There are some additional metrics we think could be added, and we will do that via written comment. However, we still are perplexed by the 4 applications as the line for exceptional studies. We note that the most recent big data studies are important, but not all of them were addressed. There are currently 4+ big data studies, and the LCD really reviewed only 1. We will be submitting the others via written comments. All of these support a higher threshold than the 4 applications for that exceptional case benchmark. And we would just note very strongly that applying more than 4 applications should not create an undue administrative burden for providers or a lack of access for patient. And that leads us to one of our primary concerns with this policy, which is the KX modifier. Overall, we have support for the KX modifier, but only if it's used as an informational modifier to allow post-payment documentation. We think that it also could be used to monitor utilization trends and to inform future iterations of the LCD. However, we very strongly want to note that the KX modifier will not work if it's used as any kind of surrogate prior authorization process. This includes generating additional documentation requirements or requests for all or the majority of claims, or functioning as any type of post-service but prepayment review on a wide-scale level. And we would just note that in the listening session for the 2023 withdrawn LCDs, stakeholders said very strongly that any kind of de facto appeal process is really going to be catastrophic to patient care. MACs are not equipped. The stakeholders noted they did not believe that MACs were equipped to handle the volume for exceptional cases, and especially with the benchmark for exceptional cases being set at 4. We really question whether there's the infrastructure in place to do that kind of wide-scale review. And we would also point out that skin substitutes are buy and bill, and so practices purchase these, and they cannot routinely absorb the cost represented by any kind of lengthy appeal or review process. We note that there is some discrepancy between the LCD summary of evidence and the billing and coding article. The LCD quantifies evidence by studies specific to DFU and VOU. However, in the billing and coding article, they are all grouped together. There's no distinction. And currently, we have stakeholders reading it in 2 completely different ways. And so clarification is needed, not just to guide providers, but we also know that Medicare Advantage plans need to adhere to the intent and the letter of these documents. And we also know that review entities and auditors will rely on them in the future. And our concern is that a doctor would use a product on a VOU that maybe doesn't have an RCT for it, but is still listed in the covered products and could have significant issues on an audit. We have strong concerns. Our other primary area of concern is the ICD-10 Group 1 list. Currently, the listed diabetes codes only contain those with the 621 suffix, and as written, this signals the cover only diabetic foot ulcers, not lower extremity diabetic ulcers. The L97.3, which is for the ankle ulcers, maps to the 622 suffix. So right now there's a very limited range of diabetic ulcers. It would only be for the very lowest ones on the foot. Perhaps most importantly, the L97 codes listed are only for 2 depths of ulcers, breakdown of skin and fat layer exposed. Patients with deeper ulcers can benefit from skin substitutes. Many product IFUs allow for that or don't contraindicate over it. And we would also add that the recent big data studies, and again, we will submit all 4 of them in our written comments did not exclude deeper ulcers and therefore function as corroborating evidence to the RCTs. And we would just like to go on record that the ICD-10 implications could be catastrophic to patient access if they're not corrected. It could be confusion or it could be policy intent, but it could be equally problematic either way. We would just remind the MACs that what's at stake, the 5-year mortality rate associated with diabetic foot ulcer amputations is very high. Chronic wound patients are at an increased risk for a gamut of utilization of resources, as well as everything up to amputation and depth. This is a utilization issue as well as a patient care issue. And lastly, something that MiMedx believes gets lost sometimes in these conversations are the good that these products could do. There are a lot of evidence gaps, which we acknowledge, but there is also an awful lot of good that these products do. And we would submit, these are from the big data papers, these next slides. And even though we recognize that the MACs cannot look at costs, these are not all economic indications. A lot of them are clinical outputs. And so we look at the readmission rate, the inpatient admission rate, and the emergency department rate all go down, with appropriate use of skin substitutes. This shows a similar pattern for the venous leg ulcers. Of course, venous leg ulcers are less prone to amputation, but with utilization, the big data studies show that readmissions, ICU stays, admissions, and ED visits are all reduced by using an amniotic product with according to practice use, which is to start after 45 to 60 days of conservative care and then continue on a weekly or biweekly basis. We would also, again, I'd like to emphasize what I said earlier, which is that none of these big data studies excluded deeper ulcers or ulcers over critical structures, and so they do act as confirmatory to RCTs. Okay, so just to recap, we really appreciate the time that Palmetto allotted. That gives us the full time to go through our slides. Again, we have overall support for this document. We truly do thank the MACs for examining all products consistently and addressing many of the stakeholder concerns from last year. But again, we also have very significant concerns, which we outlined, and we strongly encourage the MACs to look at those and to address them as part of their comment and response, but also in terms of doing revisions to address these needs. Thank you.
Thank you. Can we move on to the next presenter, please?
Hi, this is Mina Datta. Well, thank you for the opportunity to speak today regarding the draft LCD. Again, my name is Mina Datta. I'm a partner at Sidley Austin. I represent Organogenesis and filed my conflict disclosure form. We wanted to begin by applauding the evidence-based approach reflected in the draft LCD. We'll have more to say about that in our comment letter, but in our time today, we want to focus on 5 recommended changes to the draft LCD. These recommended changes are important to strengthen the draft LCD's evidence-based approach and provide safeguards for appropriate patient access to medically necessary care. So our first key point is that any finalized LCD should recognize that favorable real-world evidence, or RWE, constitutes quality data demonstrating a product's safety, efficacy, and positive clinical outcomes. FDA, NIH, and a significant body of medical literature recognize that RWE constitutes quality supporting evidence. Importantly, RWE addresses health disparities as it demonstrates efficacy and patient outcomes in populations that are often underrepresented in randomized controlled trials, or RCTs. RWE captures how care is administered to patients, which is often missing from the highly controlled environment of an RCT. RWE includes data from registries, health records, and other sources, and leverages claims data to evaluate the impact of treatments in clinical practice. Accordingly, any final LCD should cover products that have sufficient RWE support. Moving to our second point, any final LCD should specify clear criteria regarding the data and evidence required for a product to be covered under the LCD. A lack of clear criteria creates confusion. And consistent with our first recommendation, the criteria in any final LCD should specify that the evidence supports coverage when sufficient RCT data or RWE is available. Moving to my third point, any final LCD must expressly provide a process to ensure timely review of additional data and prompt implementation of coverage within 30 days following submission to the MAC of evidence sufficient for coverage. Right now, the draft LCD does not address whether and how coverage updates will occur. Failure to do so is problematic as it would create significant patient access issues and undue delays. Moving to my fourth point, the number of permitted applications should be increased under any final LCD to ensure appropriate and medically necessary care for all patients, including those with large or complex wounds who are among the sickest and most vulnerable patients in our healthcare system. Failure to do so would result in denying medically necessary care to patients and exacerbating harmful health disparities in this space. Notably, the draft LCD itself recognizes the significant problem of health disparities that already exist in the area of wound care. Any final LCD should take steps to mitigate this problem, not aggravate it. Moving to my final key point, appropriate implementation timing is critically important to address any final LCD's impact on patient access. Any final LCD should have a notice period of 1 year to ensure patients and providers can adjust to coverage changes. The proposed LCD would eliminate coverage for over 90% of the products currently covered in the skin substitutes market, which would significantly affect capacity and supply, as well as patient access to needed care. A 1-year notice period would help ensure an appropriate amount of time for provider education and for manufacturers of covered products to ramp up production to meet patients' needs. With those 5 key points in mind, we look forward to following up further with our comment letter. Thank you for the opportunity to speak today.
Thank you. Why don't we go ahead now and move on to the next presenter, please?
I'm not sure if that is me or not. Christy Blakely from Geislick.
That's correct.
Thank you for allowing me to speak on behalf of Geislick at today's open meeting. My name is Christy Blakely, and I'm Executive Director at Geislick. Here is my conflict of interest disclosure. I am a current employee of Geislick Pharma AG. Geislick applauds reevaluating the LCD for skin substitute grafts, cellular and tissue-based products for the treatment of diabetic foot ulcers and venous leg ulcers. Today, I would like to request reconsideration for coverage of Geislick Dermaguide, HCPCS code Q4203, in the proposed LCD. In the draft LCD, the Geislick Dermaguide was listed in Table 2 as a non-covered product with no literature identified. This reconsideration request is based on the recent publication of Level 1 clinical evidence in a 105-patient prospective randomized controlled trial. In the publication, the Geislick Dermaguide was referred to as PRBM, or purified reconstituted bilayer membrane, which is the generic descriptor of the product technology. You can see in the screenshot from the publication on the right that PRBM is branded in the US as Geislick Dermaguide and processed by Geislick Pharma AG in Switzerland. The clinical study team includes Dr. David Armstrong, Charles Ellen, and others as listed here. The results of this prospective randomized controlled trial demonstrate that Dermaguide is highly effective in the treatment of chronic diabetic foot ulcers, showing 85 to 92% closure rate at 12 weeks, with a percent area reduction of 93.6%. This is compared to standard of care alone of 45 to 67% closure rate at 12 weeks. In addition to the statistically significant improvement in wound closure, the Dermaguide also demonstrated favorable health economic outcomes as compared to similarly published data on other technologies that are covered by CMS. The mean graft at closure showed the lowest cost of comparable technologies with cost data published. In addition to our 105 patient RCT, additional publications include a 40-patient interim analysis of the prospective RCT, a 10-patient observational series, a 10-patient retrospective series including deep wounds, and a material characterization manuscript demonstrating the mechanism of action. We will include all of these publications in the submission of our written comments. In summary, Geislich requests reconsideration for coverage of Dermaguide, HCPCS code Q4203, in the proposed LCD for skin substitute grafts, cellular and tissue-based products for the treatment of diabetic foot ulcers and venous leg ulcers based upon the publication of this level 1 clinical evidence in a prospective randomized controlled trial. Geislich prioritizes clinical evidence to support our technologies and is pleased to see solid outcomes and improved wound healing for patients suffering from chronic diabetic foot ulcers. Thank you for your time today.
Thank you. I would like to go ahead and make sure that if you're not actually speaking, if you'll please put your mic on mute, because it tends to create a lot of background noise, which makes it difficult for everyone to hear. With that being said, we'll go on to our next presenter for Encol Corporation, Dr. Gun Asakran. Karen, I'm sorry if I'm not pronouncing your name correctly. You're up next.
My name is Subramanian Gunasekaran. I'm the president and CTO of Encol Corporation, California. I hold a PhD degree in biological sciences and also affiliated with the Society for Biomaterials for over 40 years as an active member. In this scientific organization, I currently serve as a liaison as well as the program chair for the SIG, namely Biomaterials and Medical Products Commercialization. Based on my interest and expertise in the field of biomaterials, during the mid-90s, I have been involved with FDA authorities to evaluate collagen-based biomaterials for their safety and effectiveness in device applications. As an example, I had the opportunity to inform the FDA team about the technical impossibilities of producing type 1 collagen using recombinant methods. I also played a significant role in establishing an ASTM for surgical grade type 1 collagen for the applications of the internal surgical applications. Furthermore, I have collaborated with Dr. Grace Picciolo from the FDA in industry and regulatory group meetings, focusing on tissue engineered products. I have also worked alongside Dr. Eric Sussman, who is also a PhD officer through the Society for Biomaterials. Together, we have organized webinars to shed light on evaluating a medical device based on scientific relevance of the biochemical composition of the biomaterial. Moreover, I have also been instrumental in organizing a few panel discussions emphasizing the commercialization hurdles of biomaterial-based regenerative medical products to address challenges in the field. With all these expertise, I am here to provide my perspective on the recent LCD proposal. I do admit that I have personal interest as a commercial product developer in understanding the scientific and technical relevance of the current proposed LCD. It is interesting to note that CMS and MACs have recently seemed to promote amniotic and placenta-based products as skin substitutes. The role of FDA to monitor the safety and efficacy of such medical devices is highly impaired compared to the routine market clearance of a medical device using 510K or PMA fats. During the last LCD proposal by Novitas, First Coast, CGS, Max, it was decided to call for a TRG letter from FDA to properly recognize the HCTP products. This decision was strongly objected by certain groups who argued that such decisions would dramatically affect patient care, leading to the cancellation of the proposal. Now, there is another proposal by CGS, LCD number. I don't want to go through all the things, but CGS, FCSO, NGS, Noridian, Novitas, Palmetto, the current one we are talking about, WPS, that totally removes the need for a TRG letter. I don't know the reason. However, it includes only certain products based on their clinical study data. Unfortunately, such clinical study evaluation is not adequately guided by CMS. This is my basic fundamental flaw to be immediately addressed by CMS. Otherwise, this is going to lead into a very dramatic outcome, which is going to ruin the entire healthcare system, in my opinion. Please see the below some of the observations and possible solutions. Disparities in clinical outcomes. Manufacturer-sponsored studies may not be relevant to accept. Several covered products' clinical outcomes have been assessed under high-risk categories. FDA involvement and assessment of safety and efficacy should be mandated. The proposed LCD contains controversial statements that need to be clarified. No proper pre-announcement of the need of guidance of clinical studies provided to the manufacturers. In conclusion, the list of investigators used to evaluate skin substitutes for treating chronic wounds by the Agency for Healthcare Research and Quality, AHRQ, which has been adopted to include the products under the covered category, does not seem to be adequately qualified to assess the safety and efficacy of the skin substitute. This point is also very important as it is dictated in the in the Social Security Act, Section 1886E. All of the covered shortlisted products do not seem to have a complete assessment of their safety. Safety is one of the criterions in the section it's implemented. In order to provide a suggestive solution, CMS should give the responsibility of assessing the safety and efficacy of each product to the FDA authorities. Until such a process gets implemented, forcefully thrusting the proposed LCD would have a major setback on the commercial usage of most of the skin substitute products currently available in the market. Having said the above, another major flaw in the proposed LCD is the non-availability of the specific definition to conduct a clinical study to evaluate the effectiveness of skin substitute in the proper management of diabetic ulcers and venous ulcers. Medicare should announce such guidelines for all the manufacturers and give adequate time for each manufacturer to perform such clinical studies through clinicaltrials.gov. What has been accomplished right now to declare only 15 products are covered and others are not is really a non-ethical and improper approach. Let the LCD proposal is strongly considered, and I really hate to see, based on the proposal itself, some of the MACs are already implementing these changes, which is extremely wrong, and it is non-ethical, and also it may be illegal. Thank you.
Thank you. Let's go ahead and move on to our next presenter. Our next presenter, Leah Amir from Vantage Links. Please go ahead and proceed.
Thank you very much. I'm the Executive Director of the Institute for Quality Resource Management, and my disclosure is I've been a consultant for over 20 years to the healthcare industry and medical providers across multiple medical specialties. I came into wound care through orthopedics and cardiology when the procedures tend to not go well. So that's my first introduction, which was astounding what I saw in the world of wound care. I do want to comment, and I welcome the fact, next slide, please. This particular proposed LCD, as CMS rightfully identifies, has broad sweeping impact on patient outcomes. And I do think it's important that we all pay attention to what is reasonable and necessary versus FDA. And I welcome the fact that that is the application necessary for providing care at the point, providing medical care to treat a patient with their novel conditions at that point in time. So to verify some of the areas of ambiguity, and I know others have pointed this out, I just want to clarify, particularly when a person might be contacting CMS or their regional MAC asking for additional weeks or additional skin grafts. The time that occurs before the placement of the first graft, which would be considered the conventional wound care, conservative wound care, that would be the 4 weeks prior. And then the point at which the first graft is placed would start the 12 weeks. Just want to have that clarified because I can see where in a determination of additional grafts that could really come up to be an important aspect. Again, the other thing we know is absolutely true is that some of the patients who are in group 2 who might be receiving or the group of non-covered products, they might have already been treated with those prior to the implementation date. Now, if we have a time period where we understand that on, say, October 1 of 2025 or whatever that date might be, where this might be implemented, it's kind of interesting that they will have already moved on to and not trying to use those that won't be covered, unless that coverage criteria might be on a carrier-based practice if it's based on documentation. And again, that would be extremely time-consuming. And by not covering that large number of grafts, there is going to be an access problem, which others have pointed out. So there has to be a relatively appropriate way to start making decisions on these other products. And I'm sure as a team, we can come up with that, and I'll have some ideas in my written comments. However, I do appreciate the fact that case series do not reach statistical significance. One thing we've learned over the years in teaching this to others is that by adding 1, 2, or 3 more patients to achieve statistical significance, you might not be demonstrating that, in fact, it is reasonable and necessary and leads to an appropriate outcome. We also notice here, and one of the things that's absolutely tantamount to appropriate skin graft survival and healing of the wound is appropriate wound bed preparation. They state that placement of skin substitute graft or CTP on infected, ischemic, or necrotic wounds would not be covered. And as I read through many charts when I'm asked to come in and do a practice overview, it's amazing that a lot of grafts are actually placed on what appear to be infected, ischemic, or necrotic wound beds. So what we're asking for is improved recognition of wound bed prep. And in particular, one of those products that can help that is a diagnostic that can actually identify if bacteria are present and actively involved in that wound at a degree, at a level of bacteria that's known to be related to stalling of the wound and related to at least 5 of the most highly recognized wound bed pathogens, as well as Pseudomonas. There's only one product that's FDA cleared at the class 2 level and has a preponderance of clinical evidence that identifies the presence of these bacteria and has specific labeling for the identification of bacteria at a particular level, including Pseudomonas aeruginosa. What has been happening across the United States is that many wound care clinicians are using this to remove the bacteria prior to placing a skin graft, and clinical evidence in RCT does demonstrate that those grafts will not fail when there is no bacteria left in the wound bed based at 10 to the 4 or greater. Therefore, the wound tends to heal in less time. And again, there's a lot of evidence on this, and I'm happy to provide that. And they are RCTs with a control population, not case series. Thank you. Next slide. Again, this is more information about a product that's able to aid with the diagnosis of the bacteria on the presence of a wound bed. And wound bed prep, one of the physicians I work with often has a particular protocol. It's called prepare to repair. And wound bed prep is tantamount to that healing and placing that skin graft at the right time. So we asked that maybe there could be a collaborative to help point out that just washing with saline and recognizing there's no odor is not sufficient to then place a skin graft. We're curious as well if there'll be any provisions made for those that are considered non-covered. We ask that because so many of these products are used in high volume, and I see where you identify what the basis is for that, indicating there's insufficient evidence or only case series. For an access issue, maybe there'll be a staged approach. And one of the things I think CMS is going to have to recognize, and the commercial payers that take care of the managed care patients as well, is that because something is industry sponsored doesn't mean you can't recognize that data. If the clinical trial is well designed, you have a well-controlled or comparative population where the protocol is well defined, then those studies should be regarded as they should be in a peer-reviewed journal. Just because it's peer-reviewed as well doesn't mean that it was well done, but CMS and others should take the time to see if those studies meet the criteria to demonstrate that the treatment patient population did indeed come out with a better outcome. Because our goal is collectively to close these wounds in less time so the patient can be as active as possible. On the skin grafts, noted that in some, I think in yours, it's table 2, they identify that some of the skin substitutes that are non-covered, as we pointed out, and others have as well. In the follow-up that might be provided to all of us, we're very curious what the clear delineation might be on what the manufacturers can do in order to provide information that would allow these to become in a covered category. I know there's been comment with regard to what the FDA states and the FDA relative to safety and effectiveness. And I have been involved in conversations with other CMS members regarding the 510K Class 2 designation and products that seek that through the predicate product pathway, not having to provide clinical information. If those individuals think that their product is equivalent to one that did provide clinical information and through the predicate device pathway, they did not have to provide clinical information, that, in my opinion, and based on some of the data I've seen after when, say, maybe a hospital on their own collects the data, is insufficient. So I do believe there's a recognition between FDA and CMS. Reasonable and necessary is not the same thing as safe and effective, because it has to focus on the patient, the patient's condition, and how that particular product may affect that patient. So in the review pathway that might be done with regard to seeking additional grafts beyond 4, if that is where that stands in the final decision this LCD, we do welcome any information that can be provided on what that pathway and what that documentation might look like, rather than letting there be ambiguity. It would help both the providers as well as those people on the MAC side who will be having to take those calls. Thank you very much for your time.
Thank you. We'll go ahead and now move on to the next speaker, who is Dr. Thomas Serena of Moleculite.
Well, thank you all. I'm Tom Serena, and I am a general surgeon, still boarded, although my practice now is completely dedicated to the care of patients with chronic wounds. I also run a physician-owned contract research organization with a site management organization as well. So if you ask me what I do mostly these days, it's clinical research. I've been the president of the Association for the Advanced Wound Care at the American Professional Wound Care Association, and a board member of the Wound Healing Society. So I've served on almost all the society boards as well. Today, I'd like to speak a little bit about some of the technology that we're using in preparing the patients to receive the skin substitute products. We are doing a large number of clinical trials in this space, and in every one of these cases, we're using this device, the Moleculite device. As a matter of disclosure, I have no disclosures related to Moleculite, except that I did their research, their pivotal trials, and those have been more than 2 years ago. So I actually didn't even have to disclose that if I didn't want. But otherwise, I'm not being paid to be here. This is a very important topic for us. And please advance to the next slide. So, if you look at the LCDs and even NCDs for most things, you need to have a non-infected DFU or a non-infected VLU. In our pivotal trial that we completed in 2020, which we will send to you in the written comments, we demonstrated that the clinical signs and symptoms of a high bacterial load in patients with chronic wounds are not very sensitive. I mean, not that we're going to stop doing physical exam. We're certainly not going to do that. But if you look at the sensitivity, it runs between 15 and 20% of the time. Investigators would identify a bacterial load greater than 10 to the 4th CFU per gram. And actually, that stays true at 10 to the 5th, 10 to the 6th, 10 to the 7th, and 10 to the 8th. So our clinical exam is fairly limited. Standard swab cultures that you might obtain in your hospital laboratory, which are semi-quantitative, have an accuracy of about 17%. So the current practice of determining whether a wound that you're going to put a skin sub on is inadequate to meet these criteria. You can't tell if the wound's it's a non-infected DFU or non-infected VLU because you don't have the tools. So probably right around 2020, 2021, we adopted fluorescence imaging as a guide to tell us if there's bacteria present before we apply skin substitutes. We were preparing to do a number of skin substitute clinical trials. They're in the queue right now. Several of them are already institutional review board approved. Some are already enrolling patients. All of those clinical trials use fluorescence imaging prior to applying these products to tell if the wound's infected. And so, as you can see here, I think when I look at the guidance document, I think we need to have some input here into what should be utilized to determine if the wound has a high bacterial burden. I'd like to say one more thing about clinical trials too, is just as an aside, and that is that I applaud the MACs for taking this approach that's evidence-based. This is terrific because not just some product gets approval because they've done a clinical trial, but the clinical trials advance the science of wound healing. We don't have a tremendous numbers of NIH grants. We don't have a Susan G. Komen Foundation sponsoring research in wound care, a new specialty. These industry-sponsored trials, and the industries have been very nice about letting us use fluorescence imaging. We're doing a trial coming up for STEM labs in which they've paid for and allowed me to use continuous glucose monitoring in our diabetic patients. So I just wanted to point out the fact that there's more than just getting approval in clinical trials. We're learning. The science is advancing, and we're advancing as a specialty because of it. So I applaud the MACs for this determination. Next slide, please. So again, going back to the requirements, debridement is another area. So adequate debridement. How do you know if you adequately debrided? Well, we also use fluorescence imaging to gauge debridement. You can do a video mode on this device, and in which you can see where the bacteria is located, and you can actually use it to remove bacterial burden, reduce the bacterial burden. And as I mentioned before, infection control, and I've really talked about that. So let's go to the next slide. So again, I think that this is our solution has another aspect to it as well. This device also measures the wound surface area with a tremendous accuracy. There's a lot of devices that do that now. This one, in addition to fluorescence imaging, you get accurate measurement as well. When we apply our skin substitutes, the way we do it is we use an accurate measuring device that uses digital planimetry, and then we follow the patient for 4 weeks. So I find a patient is a good candidate. I then apply 4 of the skin substitutes, and then I reassess the patient to see if they've responded. And I can do that with accurate measurements, and this device will also allow that. If the wound is responding, and is improving with the skin substitute, we then continue to apply it until we get to 10 applications or the wound goes on to achieve closure. So that's another aspect of this device that's important. I know that others have mentioned the KX modifier, and I think that as a practicing clinician and researcher, I have to tell you that is a bit of an administrative burden to us. I'd like to avoid that. I think we can easily use accurate measuring devices to tell how the wound is progressing. And then you can look at that number, and if it hasn't healed by 30 or 40% in 4 weeks, that wound's not going to heal. And you can stop the use of the skin substitute. That's how I would police, if you will, the use of these skin substitutes. If it's not responding in 4 weeks and you have good measurements to tell you that, then I think you can say, well, look, you shouldn't have applied that fifth application, or maybe it's 6. I picked 4 as a number. It could maybe 6 based on other data, but at some number, the wound should respond by a certain percentage, and at that point, we would stop using it. And the way to do that is to use technology that measures the wound accurately. It also gives you a very accurate measurement on wastage as well, and it's something that we look at in our clinical trials. How much are we wasting? And we don't have the problems that a lot of centers have in our clinical trials, because the measurements are accurate to fractions of millimeters. And so your wastage issue really it really becomes a very moot point. Next slide. So this is what it looks like. This is a 510K cleared Class 2 device. If you see fluorescence, there's almost 100% probability that you have a greater than 10 to the 4th colony forming unit per gram. Pseudomonas is unique in that it has a cyan color, as you see on the left slide, and on the right slide you see the red fluorescence that is indicative of all the other bacterial species. So we have looked at this prior to the application of the skin substitutes, and it is a terrific way to tell if your wound is ready for it. Is the wound healed? First of all, in the last month, the 30-day run-in, has the wound improved? Well, if it hasn't improved by 40%, whatever you're doing, basic wound care, not going to work. So at that point, the patients are good candidates as long as you've addressed all the other issues for the application. And then you can take a fluorescence image, see if the bacteria is present. If there's bacterial present, address that first. Use antiseptics, use more aggressive debridement, and get the wound cleared. And we'll have a better success rate, and we'll use less overall skin substitutes. So again, this is a little repetitive as far as the first bullet points. I really already mentioned these. However, I want to focus on the second bullet point, which is dark-skinned individuals. And we recently published an article in the Journal of Racial Disparity. What we found was that dark-skinned individuals, and we use a Fitzpatrick score of 5 or 6, so they have dark pigmented skin. The ability of your clinical exam to recognize infection in those patients is actually very poor, about 2.9%. So it's very difficult to tell if a wound is infected in dark-skinned individuals. It may explain why dark-skinned individuals have a higher amputation rate in many reported areas when they have diabetic foot ulcers. It may be that we're not doing a very good job of identifying the presence of bacteria. Certainly as another reason to put fluorescence imaging in before we're applying these skin substitutes. And this is just an example of debridement. You can see the red fluorescence is being removed by the curette. This is an example of improving debridement. And I think Bill Todabok and others have presented data on the reason that these skin subs fail. And the number one reason is debridement. And so improving debridement is always a positive. We will we'll include this data in our written comments. It's just the reimbursement, but you can see that the 0598T in the outpatient setting is paying roughly $239. I think, given the price of our skin substitutes, I think this is a small price to pay in order to achieve better outcomes with our skin subs. And we certainly want to keep the skin subs on the market. They're hugely advantageous for our patients. So in summary, we can improve the documentation of non-infection in diabetic and venous leg ulcers using fluorescence imaging, improves debridement and overall infection control, and allows for accurate diagnostics in measurement down to the millimeters. And we can, I think we can improve skin substitutes. We're testing that in our ongoing clinical trials. And I want to thank those companies that have dedicated themselves for conducting clinical trials, and there's quite a number of them. I've asked them to include their protocols in their written comments next week. And certainly, if the MAC has any further questions about clinical trial design, about the use of fluorescence imaging, we'd be more than happy to provide that in our written comments. I want to thank you very much for giving me this time today.
Thank you very much. Our final speaker, Dr. Banerjee, if you can go ahead and get ready for your presentation. Thank you.
Thank you very much. Apologies, I just saw the message that we are ahead of schedule. Could I start off by introducing myself?
Yes, go ahead.
I'm the Director of Global Clinical Strategy and at Smith & Nephew. And disclosure, I'm a full-time employee at Smith & Nephew. So Smith & Nephew would like to thank you for the recognition of our previous recommendations made in response to the now rescinded skin substitute LCDs. This proposed LCD establishes a path for physicians to apply more than 4 applications with documentation supporting medical necessity. And we also applaud the MAC's commitment to high-quality clinical evidence and support having evidence as criteria for coverage to improve patient outcomes. We will be providing a more comprehensive list of recommendations in our written comments. However, we want to focus on a few suggestions that we believe would be crucial to improve this further. So, number 1, ensure medical necessary treatment is accessible. Number 2, minimize the disruptions to care. And number 3, while also reducing the administrative burden on both the MACs and the wound care practitioners. So our suggestions are, number 1, remove the language stating additional applications would be considered exceptional, since larger size wounds are not exceptional and are quite common, and they will need more time and help to heal. Number 2, we suggest that the minimum number of applications to be covered be increased to at least 8, beyond which any additional applications can be covered with supporting medical necessity. And we recommend this based on currently available data from the literature. So of the 15 covered products that has been in this proposal, the RCT data for all these products suggests an average number of applications of 8. Second, in the publication by Dr. David Armstrong in 2021, the mean number of applications was reported to be 3.7. Considering a normal distribution, it is generally considered that about 68 to 70% of the population will be covered by considering the mean plus 1 standard deviation. So that brings it to approximately 8. And then the third one, which might be relevant, is a publication by Dr. Raspovic in 2018, where he classifies the wounds based on size. So wounds up to 10 centimeters square, which is almost 60% of the wounds that required about 7 applications, while wounds up to 25 centimeters square, which is almost 95% of the wounds that that we normally see, that requires up to 10 applications. So based on these, we recommend that the minimum number of applications be increased to 8 before additional applications are considered medically necessary. Regardless of the application limit established, we also support previous comments at open meetings indicating that there needs to be a more detailed description in the LCDs outlining the clinical criteria and the documentation requirements for more than the established limit. It has been stated by at least one MAC that the language in the policy will be the basis of the audit. So to ensure subjectivity in interpretation does not interfere with patient access to medically necessary treatment during post-payment audits, and to ensure that the wound care providers have a reasonable assurance they will be compensated for medically necessary care, it is important that the LCD language is clear. So in summary, we do advocate for 8 applications without exception scrutiny by the MACs, and we do recommend that the coverage criteria and the documentation requirements for applications beyond 8 be more specific. This we think will greatly reduce the administrative burden on the MACs and allow the practitioners to appropriately treat larger and more complex wounds without fear of burdensome audit. One more thing I believe is not on this notes that's being shared, and that is we would recommend a more clear guidance for bringing new products to the market because it does take time for generating evidence. So if there is a grace period for bringing these products to the market, that may also be very helpful. With that, I'm happy to take any questions.
Thank you, sir. Melissa, I believe that ends our presenters. Is there anything else we need to say, or are we done at this point?
I think we're done.
All right. Thank you, everybody. Everybody have a nice day.